Hello, today we will be discussing the topic of hereditary breast cancer with the purpose of providing a brief overview of information that will be relevant to surgeons. We will begin by defining what hereditary breast cancer is, what criteria should be used to determine who should be tested and what types of tests are typically utilized. We will then briefly discuss the high penetrance hereditary breast cancer genes and their respective risk management guidelines. And lastly, we will look at a patient case that involved management of one of these high-risk genes. Hereditary breast cancer is caused by pathogenic germline gene mutation that is passed on between generations, usually in an autosomal dominant manner. This is in contrast to sporadic cancers, which account for the majority of cases, in which gene mutations are acquired but not inherited. And this is also different from familial cancers, which may cluster in families, but are usually due to similar genetic and environmental factors, not an inherited gene. Hereditary breast cancer accounts for 5 to 10% of all breast cancer cases. There are several clues that suggest there is a hereditary cause for a cancer, including younger age at diagnosis, multiple family members with the same cancer, multiple cancers may be present in the same patient, and the presence of rare cancers. When discussing how likely a gene mutation is to lead to cancer, we use the term penetrance. Genes can be high, moderate, or low penetrance. In this presentation, we will only be discussing high penetrance genes since they confer the highest risk of developing breast cancer. The hope is that with genetic testing, we can identify the patients with these high penetrance gene mutations in order to help take steps to reduce this risk. So how do we know who to offer genetic testing to? The first step is to obtain a detailed patient history. The NCCN provides detailed genetic testing criteria for high penetrance breast cancer susceptibility genes, although other expert groups support different criteria for testing. Of note, the NCCN criteria change yearly as information is updated. Some groups also recommend the use of mathematical risk assessment models, which can predict the risk that a patient has a pathogenic genetic variant and estimate the risk of developing a cancer. However, there does seem to be a propensity of these models to underestimate or overestimate the likelihood that an individual will test positive for a pathogenic variant. Ultimately, the decision to offer genetic testing involves 3 related stages: pre-test genetic counseling, consideration of which test to order, as well as post-test counseling when results are disclosed. The most up-to-date version of the NCCN testing criteria for high penetrance breast cancer susceptibility genes is presented here. Per these guidelines, individuals with any blood relative with a known pathogenic gene variant should be tested. Also, patients with a personal history of cancer who meet specific criteria, and also any patient that has a family history that meets those criteria. Also, a patient that has a probability of greater than 5% of carrying a BRCA1 or 2 mutation by mathematical risk modeling. Lastly, patients who underwent genetic testing prior to 2014 and tested negative should be offered multi-gene testing, since some genes or pathogenic variants may not have been included at that time. The genetic test of choice for those patients meeting NCCN testing guidelines is a multi-gene panel. These panels vary, and many include genes with varying degrees of evidentiary support and actionability. The important point here is that the provider ordering the test should know which genes are being tested and understand that the methodologies, detection rates, and interpretation of the results is not standardized across laboratories. A commonly used test is the 9-gene stat panel, which can return results in a matter of days, since it is important to have the results before proceeding to surgery. Possible test results include pathogenic, likely pathogenic, variant of uncertain significance, likely benign, or benign. In practice, they're often lumped into 3 categories: a positive result, pathogenic or likely pathogenic, a negative result, benign or likely benign, or VUS, which is inconclusive but not clinically actionable. In general, a patient with a VUS should be managed based on their family history, medical history, age, and other factors that influence breast cancer risk. Of note, Ask2Me is an online tool that can be used to calculate the approximate risk of cancers associated with certain gene mutations based on what is in the current literature. So what are some of the genes we test for? As you can see, BRCA1 and 2 are not the only high penetrance breast cancer susceptibility genes. Most of these genes are actually associated with cancer syndromes, but for the sake of this presentation, we will only look at the genes and their relationship to breast cancer risk. The first is hereditary breast and ovarian cancer syndrome, caused by a mutation in BRCA1 and 2. BRCA1 and 2 are the best known hereditary breast cancer genes. 3 to 4% of women with breast cancer have a mutation in one of these genes, and they account for over 50% of all hereditary breast cancer mutations. BRCA1 carries an over 60% lifetime risk of developing breast cancer and is usually associated with triple negative disease. BRCA2 has a similar lifetime risk, but is often associated with ER-positive disease. Management includes breast awareness starting at age 18, clinical breast exams every 6 to 12 months starting at age 25, annual MRIs starting at age 25, and then annual mammograms starting after age 30. It should be discussed with a patient about risk-reducing mastectomy, and counseling should include a discussion regarding the degree of protection, reconstruction options, and risks. You should also discuss risk-reducing salpingo-oophorectomy and chemoprevention. Fraumeni Syndrome is caused by a genetic mutation in TP53. It carries a 50% lifetime risk of breast cancer, high risk of premenopausal breast cancer with a mean age of diagnosis at under 35 years old. 64 to 83% are HER2 positive disease, and there's an increased risk of radiation-induced cancers. Overall, there is a lifetime cancer risk over 90%. Management includes annual MRI from age 20 to 29, and then annual MRI and mammogram starting at age 30. It should be discussed with the patient about risk-reducing mastectomy, and if diagnosed with breast cancer, recommend mastectomy given the risk of radiation-induced cancers. Cowden syndrome is caused by a genetic mutation in P10 gene. It carries a lifetime breast cancer risk of 40 to 60% with a mean age of diagnosis of 38 to 46 years old. There is an increased incidence of multifocal disease and bilateral disease, as well as an increased risk of benign breast conditions. Management includes annual mammography and MRI starting age 30 to 35 years, or 5 to 10 years before the earliest known breast cancer in the family. Should also be discussed with the patient about risk-reducing mastectomy. Peutz-Jeghers Syndrome, caused by a genetic mutation in STK11, carries a lifetime risk of breast cancer in 32 to 54%, with a mean age of diagnosis of 37 years old. Management includes mammogram and MRI starting at age 30. You can consider risk-reducing mastectomy based on family history. Hereditary diffuse gastric cancer syndrome, caused by a genetic mutation in CDH1, carries a lifetime breast cancer risk of 41 to 60% and has a predisposition towards lobular disease. Management includes annual mammogram and MRI starting age 30 or 5 to 10 years earlier than the youngest breast cancer diagnosis in the family. Patients should consider risk-reducing mastectomy if high risk by family history. PALB2 mutation carries a 41 to 60% lifetime risk of breast cancer, which increases with an increasing number of relatives diagnosed with breast cancer. There is a predisposition towards ER-negative disease. Management includes annual mammogram and MRI starting at age 30, and patients should consider a risk-reducing mastectomy based on their family history. ATM gene mutation carries a 15 to 40% lifetime risk of breast cancer development and has a predisposition towards ER-positive disease. Management includes annual mammogram and MRI starting at age 40, and patients can consider risk-reducing mastectomy based on their family history. CHEK2 carries a 15 to 40% lifetime risk of breast cancer with a predisposition towards ER-positive disease. Management includes annual mammogram and MRI starting age 40. You can consider risk-reducing mastectomy based on family history, and also consider chemoprevention based on the fact that the cancer is usually ER positive. And now for a case study. Patient MC is a 61-year-old female found to have a hereditary BRCA1 mutation. She underwent multi-gene panel testing that demonstrated a pathogenic BRCA1 mutation. She had no personal history of breast cancer and negative high-risk imaging. She does have a prior history of a bilateral salpingo-oophorectomy over 30 years ago. She had an extensive family history, including a sister with ovarian cancer who tested positive for BRCA1 mutation, paternal aunts and cousins with breast cancer, also testing positive for BRCA1 mutations, and paternal uncle with pancreatic cancer and a paternal uncle with colorectal cancer who are not genetically tested. Based on NCCN guidelines, we ran the patient's risk through the Ask2Me risk calculator and discovered that she had a lifetime risk of developing breast cancer of 35 to 40%. We discussed high-risk surveillance versus risk-reducing mastectomy, and the patient preferred to pursue surgery. In summary, a significant number of patients with pathogenic mutations remain undetected and undiagnosed, and we need to improve